interesting project for mental health. It's not a very common case, so I hope you will enjoy the presentation. Please don't hesitate to ask any questions after Dr. Campbell finishes with the presentation.
Hi everyone. So I'm Dan, just one of the GP trainees. So this is the case presentation. So the patient is EW, and she's currently an 18-year-old female. Initially presented to mental health services at the age of 16, so a couple of years ago. Any medical background, she's got a background of type 1 diabetes, which she was diagnosed at the age of 9 at Hillingdon Hospital. And she's been under the sort of pediatric diabetic team there. She was seeing this, just a few notes from a clinic letter that was on System 1 from 2013, so about 2 years after she was diagnosed, saying that she was she understood well about her how to control her diabetes, but the values were trending a bit higher during the in the morning, and she was aware that they needed to be adjusted. And a lot of the control of her type 1 diabetes was through carbohydrate counting, and the consultant that saw her noted that she was very good at carbohydrate counting, could actually just recall a lot of values, so that would be about age 11. But otherwise looked well in the clinic. So her first presentation to mental health services was in 2020 when she was 16, and this was precipitated by her attending the emergency department with a hypoglycemic episode. She was 16 at the time, and she attended the hospital and without her parents, and didn't want her parents to be notified that she was there. She said that she didn't really want them involved, and she didn't want to worry them. From that attendance, she was actually admitted to Fleming Ward at Hillingdon because there were just general concerns about her ability to manage her diabetes. And at the time, her weight was 66 kilos and her BMI was 21. So when she was on the ward, she was, I don't know if any of you worked in paediatrics there, but the diabetes team is really involved in all of the paediatric diabetic patients. So they've got sort of lots of nurses and psychologists and consultants that are quite heavily, intensively involved in trying to get the diabetes well controlled. So she had lots of input while she was on the ward, and sort of discussions there. She had reported saying that the episode of hypoglycemia, she felt that her legs and tummy are fat since being diabetic, and to try and control that, she often doesn't eat breakfast, especially if her parents aren't around, and frequently skips lunch when she's at school, and only really eats dinner just because her parents are there, and doesn't want to cause them concern, but she frequently did purge after meals. She said she was generally a bit low in mood because of the way she perceived her body to be, and perception is that she was overweight. And she had lots of exams coming up, so she was just anxious about them. So she wasn't actually known to any mental health services prior to this. So just a bit of her family background. She lives with her parents. She's also got a non-identical twin sister. There was no sort of evidence of any sort of abuse as such from the parents, but mum had her own sort of health problems. She previously had cancer. And she had developed seizures related to stress, but she was on Keppra for it. The father at the time was unemployed and largely slept during the day, drank some alcohol, but the patient had never seen him really drunk. But she was still adamant that she didn't really want them involved in her care because of the other issues going on. She felt it would be more of a burden. She attended school, she didn't regularly, and she was academically very able, and because she was 16, she had GCSEs coming up, and she was predicted all A's and A stars, and she had plans to study medicine. She said that during her time at school, she did get particularly anxious about exams, and she reported that in year 10, so the year before, she had a boy that she sat next to in one of the classes regularly touched her inappropriately. Despite reporting this to the teachers and the safeguarding concern being raised, she felt as though nothing was really done about it and felt quite let down about this episode. But it had stopped by this point. So the risk of this time when she was seen by the mental health team was that she had had some previous episodes of deliberate self-harm, cutting to her arm with a pencil sharpened blade. That really coincided when she felt particularly overwhelmed or stressed. She had occasional thoughts of feeling life wasn't worth living, and this was particularly prominent when she was emotional or stressed, but she'd never made any active plans and no previous attempts. So following this discussion on the ward with CAMS and the diabetes team, it was felt they would have a family meeting to try and get the parents and the family on board and involved, and to try and address her concerns about her reluctance to have them involved. The patient EW gradually came around to the idea that there may be some benefits of having her parents involved, and at the meeting she did talk about her anxiety about the exams and her low mood and occasional thoughts of suicide. The parents at the meeting were very surprised to hear this. They hadn't picked up on her low mood, and they weren't aware of her purging after meals. I think following this, there's a sort of an attempt by the parents to become a bit more engaged in what was going on with her mood and her thoughts. But she generally found this a bit kind of intrusive, and because she felt there was a lot of questioning. So there was problems there, and there was lots of work that needed to be done about how to engage with each other. But from this, she was referred to the eating disorders team, and was seen as an outpatient. And there she sort of expanded a little bit more on her concern. She felt really unhappy in her body since about the age of 11, and again mentioned the issue at school when she was in year 10 about being inappropriately touched and her feeling let down by the school. And she says that really since the year 10, so when she was about 15, her body image concerns became much more prominent, as the boy that inappropriately touched her also made frequent comments about her appearance. And she started weighing herself at least once a day and often twice a day. But during the eating disorders outpatient appointment, they used the EDEQ, which is a score to assess eating disorder attitude and behaviours basically related to your shape and weight over time. And as the dotted red line there is kind of where you sort of average would be, and the blue bars are where she scores on her first assessment, so she's quite high. So there was significant concerns about her and anxiety about her opinions about her shape and weight concern, how much she thought about eating, and her attitude to food and calorie restriction. The MSc at the time of the outpatient appointment, she was well kept, good eye contact, not agitated, normal rate of tone and volume of speech. She had some low mood and said that her thoughts were predominantly occupied by purging and calorie control and anxiety as she got close to exams, but there was no formal thought disorder or delusions or any hallucinations, and she was cognitively well. This risk in terms of suicide and self-harm was largely as when she was seen in Hillingdon Hospital. She had had some thoughts, but had never gone any further than this in terms of planning or acting on them. And she did describe her family as a protective factor. So the plan from the eating disorders team was to do a family-based therapy within the team and to start her on some fluoxetine. So during the family-based therapy, they really discussed about her concerns about her family. By this point, her father had started working, but had got in trouble at work and was due for a misconduct hearing. Her mum had ongoing health issues. Despite her being cancer-free at this point, she was still having seizures, which seemed to be related to stress. The patient herself felt as though her dad did have mental health problems. She felt as though he was depressed, and she thought her mum was emotionally fragile. At the time that she was seen by the eating disorders team for the family-based therapy, it was in the middle of COVID, and she commented quite a lot throughout her different sessions about how she felt quite isolated, having school from home, and although she could maintain contact with friends through social media, actually meeting with them was obviously was very hard, and that really made her feel isolated. and she felt as though she couldn't confide in anyone. There'd been work as part of this family therapy about trying to involve the parent more in her care and how she was feeling, and also to help with the promotion of proper diabetic control and food intake. And she found these quite intense and was put off by it because she felt as though they didn't really understand what she was going through. They felt everything was quite accusatory and sort of very heavy questioning rather than working together. So back in January, when she was first seen with the hypoglycemic episode in Hillingdon, she weighed 66 kilos with a BMI of 21. The referrals to eating disorders and then the starting of the family-based therapy. So the family-based therapy actually started in April 2020. And when she was seen again in one of the clinics, her weight had dropped down to 59 kilos. And also during this time between January to May, she'd had 2 further admissions for hypoglycemia into A&E, which she was discharged from. And she'd had an attendance for alcohol intoxication. So she was found sort of unconscious and intoxicated with alcohol after some mock exams. But during this time with her friends, she was talking about self-harm, and then they'd called the ambulance. But she sobered up by this and denied any further kind of self-harm or suicidal ideation when she was sober, and she was discharged from A&E. So after these hypoglycemic episodes, there was the therapy sort of discussed ways again to try and bring the family back on board. And at this point, partly through COVID, she'd been on social media quite a bit, and there was some comments about her weight and her looks on Instagram from other boys within her class. She was still also under the care of Hillingdon diabetic team, the pediatric team there, and they had noticed that her continuing poor glycemic control and increasing HbA1c and some elevated ketones on testing, although not in the criteria for DKA at the time. But then subsequently in August of 2020, she had a prolonged admission at Hillingdon for about 3 weeks after she presented in quite severe DKA. Actually, prior to that, she had 2 or 3 admission or attendances with mild DKA and hypoglycemia, and which hadn't really sort of triggered a prolonged admission or sort of more intensive mental health input. But during this August admission, she was assigned an RMN and to monitor her even 24 hours and go with her to the toilet to check for purging and also to try and encourage food intake. Her eating did improve, but she absolutely refused to have any carbohydrates on the ward. And they came to an agreement that her carbohydrate would be made up from juice, so she agreed to drink apple juice. They did try and start a refeeding plan, just at 1,200 calories a day, but she refused daily weights and any carbohydrates, so it's unclear if she ever really achieved that. But despite having an RMN and being in hospital, she still had frequent hypos, and on one night she had 3 hypos over one night and was also still refusing the glucose juice despite having the hypo. She was discharged at the end of August with again for an agreement with mental health services and eating disorders to try a 4-week trial of family therapy. At that time, it was explained that it was either going to have to be individualised therapy or family therapy, and she agreed for the family therapy because there was a feeling that the family engagement with her was a real barrier to sort of managing her eating disorder and also being diabetic, managing her diabetes. And there was a feeling that since she was 16, 17, the parents had maybe taken an approach that once you reach age, you're more independent than maybe health professionals think you would be. So there's much more of a hands-off approach in terms of managing her diabetes from the parents at that point. So they, despite agreeing for the family therapy, they really didn't engage any of them. They missed several sessions. And from September to in the following couple of months, she had 2 further attendances with hypoglycemia and raised ketones. And although wasn't admitted for DKA because she wasn't in DKA, and her weight was about 63 kilos, but not quite at the threshold for admission. Her school life was suffering and adding to her anxiety. She was finding it increasingly difficult to concentrate at school and felt she was falling behind. She was very adamant that she was going to study 5 A levels, despite the school and the psychologist also raising concerns about whether this was the best thing for her, and in terms of how she's coping with anxiety and the stress. But she was adamant she was going to carry on because she wanted to study medicine. Due to the failure of their family therapy to engage, she then tried an individual CBT program, CBTE, for an eating disorder, which she's been on weekly sessions for quite a while now. And just incidentally, her weight had gone down again to 62 kilos by the end of 2020. So she carried on with that, and at the start of the year, she transitioned to the adult mental health services. So she had a new assessment then. Just in that preceding year, she continued to have several further admissions to A&E with DKA. So when she was actually having a new assessment, transitioning to the adult services, she talked a lot about her mood and anxiety, and obviously the clinicians were aware about her history of diabetes and DKA and her management of that. But she didn't mention it at all in the new assessment. When it was brought up, she said that she just didn't bring it up because she knew she would just get told the same thing as she had before, that you should control your diabetes. Exploring around that, she said she still had a goal of weight loss of 10 kilos. She refused to be weighed on several kind of psychology appointments as well in the preceding time. So they could only go on what her last weight was. But she continued to have that weight loss goal of a further 10 kilos. And she openly, at this point, had said that she does aim to use the insulin to control her weight. When talking about the complications and the problems and admissions with DKA, she did say that she doesn't like going through that, but mentioned the reason for that was that she knew how many calories she would be taking on with the dextrose, rather than due to any understanding of the implications of DKA or poorly controlled diabetes. So at the new assessment for mental health for the adult services, she again was well dressed. She appeared slightly anxious but was settled. Speech was normal, but her mood did fluctuate throughout the day. No thought disorder, but again preoccupied with weight and diet and calorie control. And cognitively was intact, but there'd been a few letters from the school and from the psychology just raising again concerns about her ability to cope at school and the amount of work she was taking on herself. So she's got and she's still undergoing sort of ongoing psychology now, and continues to have.
Sorry to interrupt. Maybe we should actually get to that slide. What do you think about the diagnosis and suggestions? Any trainee maybe willing to share their impressions so far on this, please? Based on the history, based on the presentation. Yes, she does obviously suffer from an eating disorder, but what do you think is at the bottom of that?
Sorry?
Just asking a question whether the audience considers that there's something else apart from the obvious eating disorder. Is there something else at the bottom of this presentation? Okay. Maybe we can answer that question a bit later. Go ahead, then. Thank you. Sorry for the interruption.
No, that's fine. So she had it wasn't just a straightforward eating disorder diagnosis. She had a few. She had quite a list of diagnoses. So there was an eating disorder, obviously, and that was exacerbated or worked in with the context of her understanding how insulin worked and declining to use it, leading to DKA. She had anxiety and PTSD and a diagnosis of emotionally unstable personality disorder. And the substance misuse seemed to be from binge drinking and alcohol excess. So I guess this is just a quick sort of just recap about the importance of controlling diabetes. Poorly controlled diabetes over time can lead to lots of problems with your eyes. You get retinopathy, you get kidney disease. It's one of the most common causes of CKD. You can also get nerve damage, you can get neuropathies, whether that's peripheral neuropathy or autonomic neuropathies, leading to gastroparesis, as well as other autonomic effects in terms of blood pressure. There's an extensive link with the cardiovascular and cerebrovascular disease, so much more likely to have MIs and atherosclerotic build-up in the brain as well. And there's also a risk that you go into DKA, which is what she did. DKA leads to an acidosis which can make them quite unwell and can lead to death if it's detected very late or very acidotic. And the correction itself can also be problematic, leading to big fluid shifts, leading to cerebral edema. And there's been a few studies that just the higher incidence of DKA does actually lead to greater cognitive impairment, particularly in executive function. So the main take-home point to this, I think this is a good case that sort of demonstrates the crossover between physical health and mental health, and also the importance of managing, of how that's managed. So, pediatric cases with type 1 diabetes are quite difficult to manage anyway as they get older and they go through puberty in the teenage years. And, and once you start on insulin, they will put weight on. But there's also, it's about how to, because I think in a couple of the letters there was a query of whether having two teams, like obviously there's the pediatric team managing the diabetes, and they also still have their psychologists and their diabetic nurses. And then there's the eating disorders team and the mental CAMS team with their approach, whether that was actually helping or actually hindering. So I think it wasn't so much, there was a feeling that there wasn't a reinforcement, that maybe there should have just been one team managing it all. But then that obviously, you need expertise from both, and that's sort of difficult to set up. So I think that, so that's one of the points. And the other one is just that the importance of managing physical health in mental health conditions, and also to, I guess for us GPs, or if you're working in the hospital, if you are seeing recurrent or poorly controlled diabetes, especially in the pediatric cases, then it may be a sign there is an eating disorder there, because kids aren't stupid, and she worked out pretty quick that when she was diabetic and not treated, she lost weight rapidly, and when she was treated, she put weight back on. So so that's it really.
She continues with this pattern of not using insulin appropriately, and basically neglecting her diabetes. At the bottom of all this, most likely is a personality disorder. That's what we think about the case so far. Any other questions? Hello?
Just a comment from me. When I worked in staff nurses in Chelsea, we used to have a square on call, and it was a talk once by one of the consultants at the eating disorder unit, and she was saying actually how there's lots of evidence to suggest that a lot of these disorders are comorbid with personality disorders. I think it was a really interesting point. Sorry, I can't remember the phrase, but about how different services.
It's just one of the unfortunate part in this case is the way she does try to manage her weight. Obviously, she's someone who is quite intelligent. She's fully aware of the consequences of not taking insulin, and she obviously does it on purpose to control her weight. Basically ignoring the dangers that's associated with it. But this is just part of the picture, and that's why I have discussed the case with our psychology team as well, even though she's currently under Vincent Square. And we think that she would need an intervention probably after the Vincent Square intervention, because it's not a good idea to have two psychological interventions at the same time. But it will be a good idea for her to have psychological intervention right after with our psychology team that would possibly address the EUPD, not the eating disorder component of it only. Because this is what she's getting from Vincent Square. She's getting the eating disorder component addressed. But I'm not convinced that that will be very helpful in the long run, having in mind that probably at the bottom of the whole presentation is EUPD. That would explain all the same.
Yeah, that makes sense. Just a quick question. Could you summarize sort of the differences in complex PTSD and EUPD? Is it very much the history of the trauma, or
Yes, so
more in the
it's also about the way the clinician looks the case. I mean, I would personally prefer the diagnosis of complex PTSD over that of EUPD, even though the differences can be minor. You know, in many EUPD cases, if you have a good history, most likely you'll find trauma, at least one episode of trauma, or it's more than one. Often it's not just a single episode, but continuous trauma. Like in this case, it was not a single episode that whatever inappropriate behavior this boy had towards her, but it was a series of those events. So it's a very minor, and it's based on the clinician's view. What's more, whether the PTSD symptoms like hypervigilance, like social avoidance in some cases, the nightmares, the flashbacks, is more, or the emotional dysregulation that we see in EUPD that goes with impulsivity, substance misuse, often. Sometimes, like I said, even in the complex cases with OCD symptoms, so like fear of contamination, we often see that in complex EUPD cases, and of course the eating disorder components, which are associated with perfectionist traits and the idea of a body image that they have in their mind, which is obviously there's something that they aim to, and often, unfortunately, that leads to problems with their BMI and physical health. So it's a matter of psychiatric opinion, but often I would prefer to put complex PTSD as a diagnosis, just because of the impact sometimes the EUPD diagnosis can make on the person's acceptance of the diagnosis. I would prefer to explain why they have the symptoms as opposed to just focusing on the name, because unfortunately the name of EUPD can sometimes be not very well accepted by the patient, just the name. But if you explain why the symptoms occur and how trauma is related to that, they will have a better understanding of the name EUPD. Any other questions?
Ask a question about, so I think we had a talk in August by somebody from CNWR about personality disorder, and I think there was a new pathway that was being introduced, the complex emotional needs pathway.
Yes.
So I'm not sure if that's been set up, so I don't work in communities. So I was just wondering how far that's been set up, and whether long term it would be appropriate for this.
I can give you probably, I'll be in a better position to answer that question than that.
Thank you. Thanks.
So, so there was a pilot that started within our local CMHTs. So there were people that were recruited in that team. This is a psychology-led team. And initially, they had very similar model to the medical team. So basically, the professionals that work there They also fulfill the role of a care coordinator for the patients that were accepted under the complex emotional needs team. Over the time, though, this model proved to be ineffective in the sense that the amount of patients that needed that service was really above the capacity of the members of staff that were there. That was other reasons led towards so the team still exists, but they work in a different way at the moment, as opposed to pure care coordination of those patients. They're introducing the group approach at the moment, which I think probably is a better idea, because often those patients, many of them have difficulties in their social functioning as well. And introducing a social environment can also have therapeutic effect. That's my personal opinion. Not only it helps with the capacity issues, still, unfortunately, the amount of patients that are under the CENT is quite limited compared to the amount of patients that suffer from emotional discrimination. So very few, let's say, not more than 10 to 20%. I don't have the official statistic, but rough numbers, I would say not more than 10 to 20% of the patients that we have under our CMHT, for example, that suffer from EUPD are under this team. And only the most complex cases are, basically. Any other questions? It will be, I mean, to continue the subject, this is something that we're looking into in the upcoming community transformation, transformation of the community mental health services, because this is a huge proportion of our patients, unfortunately, have EUPD or similar diagnosis. So we really have to look at the pathways for those patients and maybe consider different models to appropriately addressing their needs and the care, because unfortunately they are quite different, especially with the pattern of crisis compared to other mental health patients. What I'm talking about is that often those patients can go into totally unpredictable crisis, and sometimes the crisis can resolve by the time the mental health services try to intervene, which is different pattern than we know in many other psychiatric disorders. Once the patient starts relapsing, they continue to relapse progressively, which is not the case with this disorder. Sometimes they just snap out of it and get better 3 or 4 days afterwards. And that's one of the key differences in the psychopathology between BUPD like diagnosis and the other mental health problems. Any further questions? I hope you can still hear me. Sorry, it's difficult to touch on a phone.
Yeah, I can still hear you, Peter. Yeah.